Now recognize Ms. DelBene.
Thank you, Mr. Chairman, and thank you to our witnesses for joining us today. I'm glad we're here to discuss health care with the Republican mega bill stripping over 15 million Americans off of their health coverage. I can't think of a timelier topic. And while coverage is incredibly important, many Medicare Advantage beneficiaries know that coverage is just the first step to receiving needed care. One thing I consistently hear from seniors in my district is the frustration, and many have talked about this, the frustration they have with getting procedures and treatments approved by their insurer. We all know that this is prior authorization. This practice has denied life-saving care to Medicare beneficiaries. It shouldn't take multiple phone calls or even faxes to get a routine procedure approved. The Trump administration recently announced a voluntary agreement it reached with the health insurance plans to alleviate some of the problems with prior authorization. However, 4 days later, CMS announced a plan to increase the use of prior authorization in traditional Medicare. And who is allowed to contract with CMS to review prior authorization claims? The Medicare Advantage plans. So this is a case of one step forward and two step back. In 2023, Medicare Advantage plans made 50 million determinations, and of those determinations that were denied, over 80% were eventually approved. Mr. Fielder, how much time do these appeals take, and how much does it cost to constantly re-review these claims?
So I'm not aware of data that speaks specifically to the amount of time consumed in navigating appeals, but we do have data looking at how much time providers spend navigating prior authorization processes generally. If you talk about physicians, it's hours out of their work week. You talk about non-physician practitioners, it's often more, and of course the administrative staff that work for them, it can be a substantial fraction of what they do all day. So it is a substantial consumer of time for physician offices, for other types of healthcare providers, and obviously, that means it's a substantial driver of cost as well.
And not actually going towards providing healthcare at that moment. My colleagues and I agree that this is an issue, and we've been working for years to reform prior authorization. Recently, the Trump administration hosted a roundtable that highlighted the negative impacts of prior authorization. And after years of effort to reform prior authorization, it seemed like we were all on the same page. However, just days after the administration's roundtable, CMS announced their new wiser model, which contracts with private companies, including Medicare Advantage plans, to increase the utilization of prior authorization in traditional Medicare. This model is running in 6 states, including in my home state of Washington. To make matters worse, CMS has indicated that model participants will be compensated based on a share of averted expenditures. This approach appears to reward participants based on the volume or cost of care they prevent from being delivered or paid, once again creating this perverse incentive to deny care in order to make a profit. Mr. Fielder, with all that we know about the abuses of prior authorization, is it a good idea to implement this tactic in traditional Medicare?
So as some of my fellow panelists have talked about, I think it's about striking a balance. I think broader use of prior authorization in traditional Medicare could be appropriate if it's done in a thoughtful way. That being said, I'm sympathetic to the concern that the particular compensation structure that CMS is thinking about here does create incentives for plans to, or for the contractors in this case, to deny requests that should be approved. It's, I think, not clear that the safeguards that the model notionally has in effect to address those concerns are going to be adequate to the task. So I think this is the place where the devil is really in the details.
And I guess, probably the most important thing is, will this model make it easier for seniors to get the care that they deserve?
I think whatever its merits, it's hard to see how it would expand access to care.
And I think that's got to be an important priority for everyone here. Thank you all. I yield back, Mr. Chairman.
Ms. Miller,